Okay.
Yes.
So it's my pleasure to join this very huge meeting. Actually, more than 6,000 people are watching us, and it's usually a great opportunity to be with that great faculty and panels. And I will show you in just few minutes a case of CTO recanalization in the setting of in-stent stenosis bifurcation lesion. And actually, this patient was done these days in the corona pandemic, and it was really very difficult to handle, but I tried to go through the case very fast and quick, and also during the live case we went through very quick and very decided. First of all, this patient was 65 years old. He is a type 2 diabetes, presented with ST elevation myocardial infarction 6 years ago, with a total thrombotic occlusion at the proximal LAD segment at the bifurcation with a large diagonal first branch. And primary PCI was done by me with 2 stents. I remember that those 2 stents were I think, cerebral-eluting stents. This was 2 stents strategy 6 years ago at the LAD diagonal first bifurcation with very good results in 2014. A year ago, patient started to complain from exertional angina that was not responding to appropriate medical therapy, and he underwent a treadmill exercise test, which was highly positive. Then he was referred for a multi-slice CT coronary angiogram that revealed a chronic total LAD occlusion at its proximal segment with calcific lesion. Coronary angiography was done and showed, as I will show you, a CTO segment, long segment actually, with occlusive proliferative in-stent stenosis of both LAD and diagonal branch. And SPECT study showed significant myocardial ischemia attributable to the CTO area. And viability study showed that all LAD and diagonal territories are viable with a good left ventricular ejection fraction. This is the coronary angiography of the patient. As you see here, we started to cross first with a PT2 wire that was not able to cross. Then we crossed with a Gaia second wire directly to the LAD distal vascular bed. Then we tried with a second Gaia wire to the diagonal. This second Gaia tried to go through the first stent to the second stent. Then it failed. Then we go with a pot with balloon dilation of this of the old stent, trying to find the track. We opened some of the struts at the bifurcation of the stent with a diagonal stent. Then the diagonal is now can be seen. Then we tried with a second Gaia second wire that it succeeded to cross to the diagonal first. Then the balloon failed to cross first. Then we used another balloon, then kissing, as you can see here. Again, kissing of both. The diagonal and the LAD. This is very important here because we have to adjust with a non-compliant balloon the diameters of both vessels with a high pressure ballooning, as you can see here in the spider view. We park the other balloons in the guiding, 7 French guiding. Then, as you can see here, we attain flow within the 2 vessels. Unfortunately, we have to recross to the LAD again. Then crossing of both vessels. Then we used a stent, a longer stent, drug-eluting, of course, was 3.538, covering the proximal segment and the distal part with both of the proximal part of the ElNady stent. You can see here the pot. Then also do balloon dilatation, post dilation of the distal part of the stent. Then we tried recrossing with the Gaia, aiming for a second stent, but it failed. Then we changed it with a filter wire to cross to the diagonal. When we put the balloon, we put those two balloons with kissing at the two branches, and we ended with final pot in the proximal part of the ElNady segment stent. As you can see here, the stent booth. The pot segment should, of course, should not exceed the carina of the bifurcation. Then we attain Tohamy flow within the two vessels. As you see here, the two vessels are Tohamy flow and with adequate Tohamy flow, and no stent is needed in the diagonal branch. So my take-home points is that In-Stent CTOs are often more complex than those in the unstented vessels. This is by logic, of course. Bifurcation CTO lesions represent an additional complexity of the procedure, and the device-based techniques that we can use, of course, are particularly useful to cross the long-stented segments quickly. However, wire-based technique with anti-grade wire escalation still has a good role in crossing In-Stent CTOs. Which strategy to be adopted for bifurcation CTO is still debatable. And thank you.
Okay. Thank you very much, Amr. Very outstanding case. احنا معانا Professor باسم عبد الحميد. Do you like to the case, باسم? Unmute yourself يا باسم. شيل الميوت. باسم, unmute yourself.
Hi, Dr. Ahmed Magdy. First of all, it's a great pleasure to share in such meeting with you and Dr. Raj and all my professors and my dear colleagues. It's a great case, Dr. Amr. I think it was a very challenging case, and it was done very good. And thank you. I have no comment regarding the case.
Dr. Ahmed, I have one comment. Dr. Amr, no question, this is a great case, but I'm asking about passing through the stents to the diagonal with using the Gaia 2 wire. Do you think is it safe to go with the Gaia 2 wire to crossing, or it will be better to use something like Pilot 50 or something like this? It will be more safe. And if you decided to use the Gaia 2 wire, you don't think that going with a microcast will be better for the safety issue rather than using I myself, when I'm crossing the stent in the main vessel to the side branch, especially to the diagonal, I would rather use a Pilot 50, Pilot 100, even 200. This would be more safer than using the Gaia 2. And if I'm going to use the Gaia 2, I would rather use a microcast. So this is my policy. So I don't know, what's your opinion about that?
Of course, using microcatheter is feasible and easy, but if you look for the case, and from the start, it's difficult to cross, of course, to cross the two stents. But when I crossed the parent stent, I mean the ElNady stent, then I tried first to find a track just to see the diagonal, because I couldn't see the diagonal. I see the stent, but I couldn't see the diagonal. Once I saw the diagonal, I tackled it very carefully with the Gaia second wire, and it was easy to cross. But it was not easy to cross later on with the Gaia. And for that, the sake of the safety, for not to make any disasters or perforations, or I used here at that setting a Filter XT wire that was passing very easily through the struts, because the lesion was treated before with a two-stent strategy, and it was a mini crash technique. So I can imagine the anatomy, the detailed anatomy of the two vessels and the two stents, and where exactly I can go through the lesion with my wire. But of course, you can use microcatheter. You can try pilot 50 or 100, or you can try whatever you want. But for the sake of the time, we did this case actually in 9 minutes. So we finished it in 9 minutes, and it was very quick, because we have to decide, because that was during the pandemic of Corona, and this was extremely cautious. And you know that we actually did it in unconditioned or extremely difficult conditions of PCI.
Which cases of In-Stent, Professor Amr, that you need intracoronary imaging? In-Stent stenosis.
Yeah, of course, IVUS is mandatory in such cases. Usually, I use IVUS in maybe more than 2/3 of the cases, but sometimes you are obliged to move forward fast. You are in an institute that it doesn't have IVUS with you, so it depends on how you can feel the vessel, how you can imagine what you are doing, and this, of course, depending on the skills of the operator. But as a standard, if you have IVUS with you, you have to see what is going on. It may help you to find the ostium of the diagonal more easily. It can help you to make the wire manipulation more easily, and not to cause dissections or perforations.
Thank you, Dr. Amr, very much. And
I try to make it very short, very simple, to stick to the time.
Yes,
because it's a quick hitting
yes.
because of the time. Thank you.
So now we welcome